Hi, my name is Sue Mallet. Welcome to this short course on designing diagnostic test accuracy studies, the absolute essentials you need to know. I work at the Centre for Medical Imaging at UCL in London in the UK, and I'm going to share with you important tips I've learnt designing these studies over the last 20 years. The Introduction to Diagnostic Accuracy is a series of short videos, each highlighting a key learning point. In each video, there are short activities where I encourage you to pause the video and think. If you're watching with colleagues, this is a great opportunity to discuss together. After each activity slide, I'll share with you my thoughts and insights. This is Part 8, Reference Standard. So in Part 1 of these introduction videos, we discussed the terminology and the words used to describe components that go into these diagnostic studies. So you have participants who you enroll in the study, you have an index test, which is the test you're interested in, you have the reference standard for the target condition, and that target condition is often the presence of disease, and then you have your outcomes. These are the results that you measure from the study. Okay, in this video we're going to talk more about the reference standard, which is the test or tests that you use to define the target condition, often the disease presence. Okay, so when we were talking about a flow chart of patients, we were doing diagrams like this in several of the previous videos. So we had our study participants, they were all getting the index test, then they were all getting the reference standard, and then everyone goes into a 2x2 table of results. And this is what that 2x2 table of results looks like. So here you have the index test and whether someone was positive or negative with the index test, and you have the reference standard, which is how you're defining the target condition, and that's people are either positive with the target condition or they're negative with the target condition. And this 2x2 table gets you those 4 important results that you're really interested in: the number of true positives, so people who are identified with the index test of the people who actually have disease. You have the true negatives, so these are the people that the index test correctly detects as not having disease, and they are in the reference standard says they don't have disease. Okay, you have the false positives, where the reference standard identifies they don't have disease, but the index test says they have. And then you have the false negative, where the reference standard says they have the disease, but the index test says they don't. Okay, so we're going to launch straight into a pause and think exercise, which is getting you to think about how you interpret the reference standard. So one of the problems in a lot of diagnostic tests is that people take a reference standard and they way over interpret it, and then they try and make the study mean something it simply doesn't. So here's an example of a study that looked at the diagnostic accuracy of a new test for SARS-CoV-2, and they enrolled hospital workers who had symptoms typical of COVID. So SARS-CoV-2 is the virus underlying COVID-19. And the test was an antibody test, which was measuring IgG in the blood, and it was measuring antibodies to the virus. And it compared them to a reference standard test of detecting virus RNA, so that's a PCR, RT-PCR molecular test. And this reference standard test was looking at nasopharyngeal swabs, so mouth or throat swabs. Okay, so one of the things in this study report is that initially when the study was written up, they wanted to interpret the reference standard in lots of different ways. So just to remind you, the reference standard is actually an RT-PCR test for the virus. Someone's got the virus in their nasopharyngeal secretions. That's all we know. However, initially when the study was written up, as it went to reviewers' comments, it actually had lots of different interpretations that came from the study. One was deciding who had immunity to the virus. One was that the test could be used to work out who was safe to work on COVID wards without PPE and without vaccination. This was prior to vaccination. Understanding the sensitivity of the test for diagnosing close contacts of those infected. Being used for a seroprevalence study of the population to understand how many people had been infected so far, for the diagnosis of people with current symptoms, and for the diagnosis of people who had symptoms more than 21 days before. And so what I want you to do is go back to this reference standard, which was an PCR test for presence of virus in the nose and throat, and say, can I use the study results for any of these interpretations? Okay, so when you're interpreting that study, you're basing it on how good is the test to the reference standard. So have a hint, what is the target condition that reference standard corresponds to? Okay, so it's going to take you a little while. Go through each of these in turn, and you're going to say, does a reference standard correspond to immunity to virus? Okay, and that's what you're then going to make a decision about whether you can use the study results. Does a positive test with the antibody confirm the reference standard test of immunity to virus? Okay, good luck. I look forward to having some good discussions with you in the next few slides. So pause the video here. This is going to take you 5 or 10 minutes, I think, and come back. So welcome back to this pause and think discussion. What we're doing is we're trying to work out whether in this study result for an antibody test to COVID-19, where they're picking up IgG antibodies in the blood, and they compare it to a reference standard test of a PCR for virus in the nose and throat. What can they conclude from the study results? Can they conclude that this test would be useful for deciding who has immunity to the virus? Okay, and when we talk about immunity, what do we mean? We need to know that before we can decide whether the antibody test in the blood would be useful for immunity to the virus. So immunity is usually talking about when someone won't notice that if they've been infected with a virus. Or sometimes used to say they won't be infected. Okay, so different people mean different things by immunity. I think of immunity as that someone won't notice if they get infected by the virus because of how their immune system is protecting them. But some people think that they won't be infected by the virus because of how their immune system is protecting them. Okay, so let's look at the reference standard here. So the reference standard is that they actually have virus. Okay, it's nothing to do with their immune response. Okay, if we wanted to say that they have immunity to the virus, we'd need a reference standard that corresponds to someone who has immunity to the virus, and that's either someone who won't notice that they're infected or someone who actually won't have a productive replicating virus infection. Okay, and that reference standard about immunity to the virus would have to include T-cell responses as well as knowledge of the antibody levels and the antibody responses, including the time and the type of antibody, because actually if you want to say someone won't be infected, you need to say they have the antibodies protecting them at the place that the virus would enter. And in the place that the virus would enter, for SARS-CoV-2, for a lot of infections, is the nose and the throat. That's the place where we first see the virus actually independently in replicating. And IgG antibodies in the blood do not tell you about the antibodies in your nose and throat, which are a completely different type of antibody called an IgA antibody. Okay, so no, we can't use this antibody test for IgG in the blood to tell us anything about who will have immunity to the virus. Okay, can we use it to decide who's safe to go on the COVID wards? At this time there was no vaccination available, and the question is, are they safe to go on there with or without PPE? And preferably without PPE because there was a shortage of PPE. If we wanted to say it's that this test can be used to decide who is safe to be on the COVID wards, we'd have to say a positive result says they're safe and a negative result says they're not safe. So then our reference standard would have to be a reference standard that we knew ensured people were safe to work on the COVID wards. What is our reference standard? Our reference standard is about whether they have a virus in their nose or their throat. Okay, so that tells you nothing about the immune response. It tells you nothing about whether they will get a serious infection. So basically, no, this test does not say anything about who is safe or not safe to work on COVID wards, because the reference standard does not correspond to that. Okay, so what about understanding the sensitivity of the test for diagnosing close contacts of those who are infected? Well, there's a couple of problems with this. One is that the study is only key workers who potentially had high levels of virus infection and who had symptoms. So SARS-CoV-2 is asymptomatic in many people. The estimates range from at least 40% to much higher. It might be much higher than 40% of the people who are asymptomatically infected. And so key workers with high levels of virus infection, if we then look at their co-workers and ask whether they've got antibody responses, the key workers are not typical of people in the community, and the antibody responses take between 10 and 21 days to develop. So actually, it's a pretty useless test to look at who could be contacts of those who are infected. Can it be used for a seroprevalence study of the population to understand how many people have been infected so far? Okay, so for this to be true, we would have to say the reference standard would have to be telling us everyone who'd been infected so far. So does a PCR test tell us everyone who has been infected at some point? Well, okay, if we had a PCR test at the right moment for everyone, then maybe that would be helpful. But the problem here is that this antibody test actually worked extremely poorly in asymptomatic people. And there were a couple of, there were like 18 asymptomatic people in this study. Can we use this test to look at the seroprevalence of the population to understand how many people have been infected so far? The answer is no. SARS-CoV-2, this study actually only had very few people who were asymptomatic in it. And the people who were asymptomatic, there was an extremely low level of detection, so less than 20%. So, but SARS-CoV-2 is asymptomatic in many people. Estimates range 30, 40, 50, much higher percentage of people who are infected are asymptomatic. Okay, and so this study was only supposed to be in key workers who had symptoms. It had a few asymptomatic people in it. And so we can't actually, to work out the seroprevalence of a population, we'd be looking at community setting. We'd have a much higher percentage of asymptomatic people. And so we would actually need to know a lot more about the accuracy in asymptomatic people. And if we took the accuracy results from a small number of people who are asymptomatic in this study, we would say it would be actually fairly rubbish at looking at the seroprevalence to understand how many people had been infected so far. Can we use it for the diagnosis of people with current symptoms? And the answer is no, because it takes between 10 and 21 days for antibodies to be detectable in blood after a virus infection. That's pretty much all infections and is the same in SARS-CoV-2. So no, it's not useful for that. And can we use it for the diagnosis of people who more than 21 days previously had symptoms typical of COVID? Well, the answer is yes, probably we could. So the people had symptoms. The study looked at people who had symptoms, and it looked about whether they had virus infection or not. So we could use, so if people had had symptoms previously and 21 days later, we could probably say that this test could be used to work out how many of those people with symptoms had had COVID-2 as opposed to a different virus that gave similar symptoms. So probably, however, this study used key workers who might typically have been infected at higher doses of virus than the community infections, and that might result in potentially higher levels of antibody. And so this is not quite the right population for that. It might be, this is the best thing the test could be used on of the uses that were proposed. But again, the time interval, when it says more than 21 days, it would have to be more than 21 days, but probably less than 6 months or 12 months, because the antibody levels in the blood do decrease, and we don't actually know at the time of this study we didn't know the rate of decrease across time, and we didn't know at what point the antibody test would no longer be able to pick up the reduced amount of IgG in the blood. Okay, so I hope you enjoyed thinking about all those different interpretations of what the study results mean, and I hope it was very informative for you to actually see that it is really, really important when interpreting what a study results mean in a diagnostic test accuracy result, that you have to go back to the reference standard, because what you are doing is you are comparing against the reference standard, and the reference standard here was about detection of virus in the nose and throat. That's it. It was not about detecting people with immunity or who are safe to go and work on COVID wards or anything. There was a very clear and limited definition of what this reference standard was and how we could then interpret it. Okay, so when we're talking about reference standards, in the last example we just had a single test. That was a RT-PCR test for COVID-19, SARS-CoV-2 virus. So reference standards can be a single procedure or a single test, but they can also be multiple procedures. And when we have multiple procedures, we have to have some sort of system for working out what to do when one of those tests is positive and another is negative. Okay, so there are generally 3 ways that we'll do that. There's either a rule-based approach, where you have a rule for if this one, A is positive, B is negative, and C is positive, then that means. So you have a little formula for how you're going to interpret them. Or else you could have a panel of people, so a panel-based response. So here you could have a set of humans who look at it and look at all the results and go, okay, in this case, A was really positive, B was only slightly negative, and C was slightly negative, so we're going to say that's positive. And then you could also use model-based methods. So there are some statistical methods that we can use to weigh up the different tests, or else we can just follow the outcome. So we can wait a long time and follow up what happens. So I'm going to give you an example in the next slide of all of these. So a single procedure or test might be when you look at the histology and you look to see whether you've got any cancer cells in patients who've got tissue samples where you're testing for cancer. Another situation might be where you've got something and you want to know whether there's a bacteria present. You might do a cell culture. Take a little sample, put that into some broth and grow it up over a few days and work out if there are bacteria present. Okay, where you've got multiple procedures or strategies, you can have a rule-based procedure. So that's a composite reference standard. And the international consensus definition for fungal infection is an example of that. It's lots of pages, but there's a rule that you can follow, and you can just go down the chart and work out whether someone has tests and symptoms that are typical of fungal infection. It's likely they had a fungal infection. Example of a panel-based decision where you have humans looking through all the test results and coming up with a decision based on multiple test results. You can have things like metastases of cancer, of baseline imaging. Other examples, you can have things like behaviour based on treatment or follow-up at imaging. Lots of different things where you can have multiple information that a set of human beings then interpret. For the model-based methods, one of the statistical methods is latent class variable analysis, but you could also have some sort of rule-based system. And latent class has been used in paediatric TB diagnosis. We do also have outcome-based things. For example, in ovarian cancer, if you don't see an obvious mass, you can follow them up, and then you can work out by following them up if they have any signs, symptoms, or any masses appear across a period of time. Okay, so here's another pause and think exercise, and we're back to lung cancer, diagnosis of lung cancer. And what I want you to do is I'm going to show you a flow chart for patients in the diagnosis of lung cancer. And what I'd like you to do is identify the reference standard, and I want you to identify them both with patients with the disease and for patients without the disease. Okay, so this is really highlighting to you that sometimes the reference standard is different in people with and without the disease. There'll be a future video where we'll talk about why that's a problem and how it can lead to bias in a study. But here I just want you to notice that reference standards can be different in people with and without disease. And we call this verification bias when we actually do the analysis and look at these studies. And the other thing I want you to think about is whether the results for the reference standards are available at the same time in people with and without disease. And maybe there's some results that are available at different times in some people. Maybe there's results available at multiple times, both within people with and without disease. Okay, and again, that sort of thing can lead to bias, and I want you to be alert to pick that out and notice it when you're reading studies. Okay, so we've got some patients with persistent cough. They're attending their primary care doctor. Some of them are getting other diagnoses. They might get asthma as a diagnosis, or they might just be really insufficient suspicion to refer them on for this cough being anything to do with lung cancer. But those who have the persistent cough referred on for lung cancer will get a CT or a chest x-ray at the hospital. Some people, that scan will identify it's normal, there's no lesions and therefore no suspicion of cancer. And some people may actually have a lesion identified, and then they'll go on for further imaging based on that suspicion of cancer. And then if a suspicion of cancer is still upheld, they may go on to have a biopsy taken, and then that biopsy sample is used for histology to identify whether there are cancer cells present or not present. Okay, so I'd like you to think about and identify the reference standard for those with disease and for patients without disease. And also think about which results are available at which time and which results might only be available on follow-up, and so at a different time. Pause the video, have a discussion, or have a think on your own. Okay, welcome back to the Pause and Think discussion. So we were identifying what the reference standard is in those with disease and without disease. So for the people who are found to have lung cancer, that reference standard comes from the biopsy and the histology. Okay, so that's a nice clean reference standard. However, there will always be some patients who are too severely ill to receive the biopsy. And so the presence of a lesion on imaging and maybe their death from cancer in the sort of time frame that you would expect may be used instead as a diagnosis that this person had lung cancer. In the people who the reference standard for people who for no lung cancer, that could be a range of things. It could be the biopsy and histology, so they get right down to this stage and then the histology shows it's not cancer. Or it could be people who've got no suspicious findings on their CT or chest x-ray and followed up, have no symptoms or any follow-up imaging that shows any suspicion of lung cancer. It could be people who actually had symptoms that were typical of other diseases and actually never went to the hospital for a chest x-ray, so they could have been put on some asthma medication. It could have been clear that it was asthma. And for all of the people without, it's likely there was a follow-up to see whether they actually developed any signs or symptoms of cancer as well. And again, from my description, hopefully you're able to realise that these test results are not all available at the same time. And that's both for the patients with lung cancer and the patients without lung cancer. They're getting all sorts of tests at different time points that confirms whether they have disease or not. But in particular, the major contrast that's different is that in the people who don't have lung cancer, there will usually be a follow-up, and that follow-up might be 1 or 2 years, whereas the biopsy histology results may be available within a month of them having being identified with a suspicion of cancer. So, well done. This is you've got through 8 videos so far, if you've watched them all. And the sort of things we've learned is that when we're looking at designing diagnostic accuracy studies, we need to be doing the studies in normal clinical practice where we'd like to use a test. And we need to be doing it on patients who would usually get the test and on an unselected of patients. And we need to have pinpointed the time in the clinical pathway that the test would be used in future, and we need to be using those patients for our diagnostic study. And so it also needs to be at the same time point in terms of the other tests and at the same time point in actual time to when we'd want them relative to everything else in current practice. And if we want to replace the test that's being used in current practice or add on to it, we actually need to be comparing and including the current practice in our study. And we need to be using a reference standard that's good enough to interpret for our purpose of what we want the test. So the reference standard is really important, that it is actually related to what we want to conclude from our study. And when the people who are actually interpreting our new test, our index test, need to be using the same clinical information as is usually used when interpreting a test, so they may know something about the age or the prior conditions or prior symptoms of that patient. And the diagnosis needs to be being done by people who would usually conduct the test and interpret the test. So if it's a test to be used at a patient's bedside as a point of care test, this test needs to be done in our study by people who are doing it as a point of care test. And the people who interpret the test, is that test going to be interpreted by someone at the patient's bedside? If so, they need to interpret the test. If the test, the sample is going to be sent off to a laboratory, and a professional licensed laboratory is going to do the test and interpret the results and send back a test result to a doctor who is then going to interpret the test from the laboratory test results. That is a procedure that needs to be used in the study. Okay, so we're going to go into some more of these things in future videos, but this introduction was covering the basics, so hopefully you've got some of the basics here. Did you do well in the activities in this video on reference standards? Well done. And I look forward to seeing you in part 9, which is about tools and checklists to help you design and report your study.